award is presented to a blood service or centre from a developing country that has made a significant contribution in strengthening transfusion practice within the country. It enables blood services or centres to attend an international congress of the ISBT and to organise an educational symposium. This year's award is given to the Lifeblood Centre from Gujarat, India.
We thank ISBT for recognizing our significant contribution in blood transfusion and your remarkable work to improve the safety of blood transfusion worldwide. Thank you.
We thank from the bottom of our heart to all the officials of ISBT for presenting us the most prestigious Developing Country Award 2020.
Thank you for the invitation to join you today at this important event. On behalf of the International Society of Blood Transfusion, I'm really delighted to be part of it. So thank you so much for the warm welcome and the introduction. I've left a little bit of time, I hope, for some questions and discussion if there is time in the program. I was asked to speak about appropriate transfusion practices. Before I do that, I'd like to say a few words about ISBT. As I think many of you know, we are a scientific society, a professional society founded in 1935. And we are an international community of professionals sharing knowledge to enhance transfusion practice. And there are many opportunities to be part of this and to advance knowledge and education. Some of you will have been over the last few days at our Congress online. And one important part of our work is advocating for the welfare of blood donors and patients. And as I think I heard just a few minutes ago, everyone is aware that World Blood Donor Day is coming up this coming week. I look forward to seeing you there, and I've been following some of the activities on Twitter and other social media from India about preparing for World Blood Donor Day. Excuse me. So I was asked to speak about appropriate transfusion practice. And this is a very straightforward concept in many ways. Surely it's just getting the right blood to the right patient at the right time and for the right reason. That seems simple enough, doesn't it? Well, as I think we all know, nothing is ever simple. And in transfusion medicine, we have to get it right every single time. So I think appropriate transfusion practice is all of those things, but I think it's more. And we need to understand some of the additional things in order to transfuse appropriately. So, for example, we might do all of those first four things, but what do we understand about the outcomes for our patients? Are we measuring them? Are we improving them? Are we asking our patients how they are doing after a blood transfusion? What about the costs? We all know that even with volunteer donors, it is still a huge investment to provide safe and adequate supplies of blood for transfusion. And those units are very precious. So we want to make sure that we are using the blood donors' gifts appropriately, and also the money of the community to make this all happen. So we want to minimize waste. Some of you will be familiar with this document from the World Health Organization, talking about its strategic objectives in advancing universal access to safe, effective, and quality-assured blood products for this period. And you can see that their 6 strategic objectives are having an appropriately structured, well-coordinated, and sustainably resourced national blood system, having an appropriate national framework of regulatory controls, including national standards and quality assessment programs, having functioning and efficiently managed blood services, having effective implementation of patient blood management to optimise the clinical practice of transfusion, and that's what we'll be focusing on today, but also having effective surveillance, such as hemovigilance and pharmacovigilance systems, supported by comprehensive and accurate data collection systems, and the many partnerships and collaborations and information exchanges required to achieve these priorities at both global, regional, national, and of course, institutional levels. So I've mentioned patient blood management, as mentioned by the WHO. I think everybody in this audience will be familiar with the concept of patient blood management. But just to summarise, it's an evidence-based, multidisciplinary approach aimed at optimising the care of patients who might need a transfusion. It puts the patient at the heart of decisions made around blood transfusion, promoting appropriate use of blood and components, and the timely use of alternatives where these are available. And so some of the elements of this concept include making sure we have the appropriate clinical indications, minimising blood loss, and optimising the patient's own red cells, but also other resources. And while patient blood management can reduce the need for allogeneic blood transfusions and healthcare costs, it also ensures that blood components are available for the patients who most need them. And PBM is now considered an international initiative in best practice for transfusion medicine. So this is the ISBT working definition. There are others, and they're all, broadly speaking, very much aligned. So if I go back to those bullet points on the previous slide about the right blood for the right patient, etc. So let's think a little bit about the right blood. Here's a picture from our laboratory, everyone working very hard in the lab to get these precious products out the door. And as we know, historically, there's been a very important safety focus on the infectious safety of our blood supplies. This review is a couple of years old now, but it was really a very nice summary of some of the concepts and progress prepared by Mike Bush and colleagues. And some of you will know that just 2 days ago, Mike Bush took over from me as the president of ISBT. And you can see here that at least in the United States, some of these viral infections are now largely addressed in terms of the safety of the blood supply. hepatitis B, hepatitis C, and HIV. But we also know how many infectious threats there are to the blood supply, including new ones that we need to be constantly vigilant about. So I think the concepts as well as the statistics from that paper are very well worth reviewing. Excuse me. So what are the elements of blood safety? Well, we need a safe product. We need to have those policy and regulatory and quality frameworks that WHO mentioned. We need to have volunteer and low-risk blood donors. And we need to have high-quality manufacturing processes so that we will have a reliable and safe product every time. But blood safety is more than just what's in the bag. It's how we use these products. It's safe practice. And I'll come back to these points again, but it's very important that we try to strengthen the evidence base for our clinical practice. There are many areas in which we still don't have good quality evidence about how to make transfusion decisions in various clinical contexts. To provide safe blood to the patients, we also need robust hospital, clinical and laboratory systems. And we need to focus on this goal of optimal clinical practice supported by haemovigilance, and I will come back to that. So for this audience, I don't need to say in detail some of the many steps that we have to take to achieve blood safety. Some of them here focus on blood donors, including educating the community and educating our blood donors and selecting low-risk donors. Those manufacturing and quality systems that we mentioned previously, including recall and look-back processes if we need them. And then various factors of clinical practice, including providing education and training for our staff, informed consent for patients so they understand what is being proposed. I've mentioned evidence-based clinical guidelines, haemovigilance, and I'm a clinical researcher, so I think that we've still got a lot of opportunities for research here. So if you're a young physician or scientist or nurse, I think there are many opportunities here for all different types of research, including a further study. And I think we're just starting to understand the many, many complexities of providing the right blood. So it's essential, of course, that we give people blood that is properly blood group matched, ABO, RH, etc. But there are so many other factors related to the donors and their donation, related to the components, and of course related to the recipient characteristics that influence the safety and outcomes of the blood transfusion. And this was just a very nice review paper, results paper with also some important concepts as part of a review. I'd recommend it. And I think now we know that in addition to giving people a safe product in the bag and that we properly cross-match it and provide it, there are so many other factors. For example, at a molecular level, we need to know much more about compatibility between our blood donors and our patients. And here was a very nice international study looking at universal blood donor genotyping platforms so that we can understand much better the profile of the products that we are presenting to our patients. And that we need to understand our patients' immune profile much better. You can see here some examples of how we could use genotyping much more in transfusion medicine for a whole range of clinical scenarios. For example, patients with autoimmune hemolytic anemia, patients who have received immunoglobulins or monoclonal antibody therapies, obstetric patients to try to determine whether they need RHD immunoglobulin, and a number of other opportunities here. So I think when we're thinking about the right blood, it does have to be safe. But increasingly, I think we're focused on how can technology help us to understand what is a better match between donors and products and patients. So moving on to the second bullet point, which was about the right patient. This was a patient of mine, a lady who had had a pregnancy previously affected by fetal-maternal alloimmune thrombocytopenia. And I show this picture very often. Firstly, it's a lovely picture of a mother and her baby. The mother's name is Monica and the baby's name is Olympia. And I looked after them many years ago after the mother had had a bad outcome in a previous pregnancy. And I think it reminds me very much that patient blood management is just not just about elective surgery or that sort of thing. It's about every patient and what they need in their particular circumstances. So how do we think of getting this blood to the right patient? Well, many of you will be familiar with the Haemovigilance report from the UK, Serious Hazards of Transfusion. And this is from an extract from last year's report, and the next report will be launched in July. You can see here that there are, on the right-hand graph, that there are 3 sections. The top section is described as transfusion reactions which may not be preventable. Many of those, for example, are biological, due to biological factors that we may not have control over or we may not understand, or some other procedural factors that may be difficult to control. The next section is serious complications of transfusion that are possibly or probably preventable by improved practice and monitoring. And then this large section at the bottom, which accounts for, as you can see over the years, thousands and thousands of cases, are adverse events, adverse incidents due to mistakes. Over or under transfusion, delayed transfusions, transfusions that did not need to be given, handling and storage errors, errors related to immunoglobulin, such as anti-D, and this largest group at the bottom, incorrect blood component transfused. So a blood transfusion that was meant for somebody else or which did not meet the patient's needs. And so every year SHOT publishes a figure like this. And you can see here how many of the reports are related to errors. So this is clearly an area where we need to do better at getting the blood to the right patient. So why is this so difficult? Well, here's an example from a research project that we conducted. And the purpose of the research was to try and understand the costs of transfusing a patient with beta thalassemia major, a unit of red cells in our outpatient setting, so our day centre. And in order to determine the costs, we had to map and cost every single step in all of the processes involved in getting that unit to the patient. And you can see here, you don't need to see it blown up in any detail. You can see here that in this one process, doesn't matter really what it is, there are many, many steps. And those processes and those steps intersect and need to connect with other processes for this all to happen in a smooth and efficient and safe way on the day of the patient's transfusion or even in advance. So we mapped 31 processes, of which there were more than 600 individual activities to get a unit of red cells to a patient with beta thalassemia major. So it really reminds us of the complexity of our processes and how we need to understand and try and strengthen those processes. And sometimes I think of this as the many chains and the risk of a weak link in the chain, which might be caused by failure of training or something like that, or human error. People are distracted, tired, overloaded. We need to think, how can we strengthen these processes for safety reasons? And we all know that the pre-transfusion bedside check is one of the most important elements in preventing an incorrect blood component transfused or wrong blood to patient, for example. And I was very fortunate to be in Japan recently for their national meeting, and I was looking at some of their materials, and you can see here this very nice a tool about transfusion reactions. And they mention here how technology can help us to make sure we're properly identifying the patient and the unit of blood. And I really liked this image of the nurse checking using this personal digital assistant. And if the unit is compatible, then the nurse is smiling. But if the unit is not compatible, the nurse looks like most nurses I've seen when things don't go well. So the nurse is very unhappy here. And I think it emphasizes how important it is to get this right. So for something that seems simple, we need to do better by understanding and improving the process. So we've got the right product, the right blood and the right patient. What about at the right time? So here are some more examples from the UK SHOT program. And they have a special category and a special chapter devoted to delayed transfusions. And you can see here in the last year alone, they had 133 cases of serious complications reported to them because of delay in transfusion. And they define this as where a transfusion was clinically indicated but was not undertaken or was significantly delayed, or non-availability of blood components led to a delay with an impact on patient care. And these are not all restricted to emergency transfusions, although many of them were. And you can see here that the number of cases reported to SHOT in this category are going up year by year. That's probably not because there are more delays, but because we're more aware of them and they're being reported. There were 12 deaths from delayed transfusion events. And you can see here that these were either definitely or probably or possibly related to the delay. And tragically, there are 2 examples of babies who died from bleeding after an elective procedure, which is rare. But the main problem here was recognition of the severity of hemorrhage and delay in activating the major hemorrhage procedures. There were also deaths in other patients, including elderly patients with gastrointestinal bleeding, some of whom were on anticoagulation. So these are tragic cases, of course, but they are very important tips of the iceberg about what is probably happening in my hospital and your hospitals that we need to do better on. So SHOT provided a number of key messages about delayed transfusions, about how multiple delays in terms of decision-making, activating major bleeding protocols, actually issuing blood and then transfusing it, that these delays can be cumulative, that good communication is essential, that many people need to be involved and are involved in the management of the hemorrhage, but those people also need to be participating in the learning from some of these events. And I won't go through all of these key messages here, but really I would recommend this report to you, and certainly it's been very helpful in our hospital, including this point that says, using the example of obstetric hemorrhage, training and drills are essential, because even if these cases are not happening very often, or maybe especially if they are not happening very often, people are often unfamiliar with what to do. So training and drills are essential. So what about the right reason? So I'd like to spend a few more minutes on thinking about the right reason. So I mentioned patient blood management earlier, and many of you will be familiar with this concept of the 3 pillars model of patient blood management. And I think it's very helpful as far as it goes, but I don't think it covers all of the aspects that we need to think about for patient blood management. And I won't go through this 3 pillars model because you already know it and you live it in your own day-to-day practice. But I like to think about PBM as being, what is the optimal management for this patient? Might a transfusion be needed, or are there alternatives? And if a transfusion is needed, how is it best delivered and evaluated? So the way I think about this was summarised in a review that we did for the American Society of Haematology a couple of years ago for the annual meeting. So I think we start with the patient. What are their symptoms? Also, what are their values and preferences? What are the patient's comorbidities, their performance status, and also their laboratory results? So in many cases, we often think of laboratory results as the most important thing, but I think they're only part of the story here. And we need to think what alternatives to transfusion are available and would do the job in the time frame that we have available. Is this a person who is suffering symptoms this afternoon, or is this someone who may be coming up in weeks or even months for elective surgery? If the person needs a blood transfusion, we need to make sure we select the right product. We need to make sure that there will be opportunity for close monitoring and careful administration of this patient. And then how will we make sure we recognise and respond and report adverse events? And then what about the outcome, as I mentioned at the start of this presentation? How do we evaluate the symptoms and the relief of symptoms after a blood transfusion? How do we capture health-related quality of life for our patients? And this might be one thing for somebody having a once-only transfusion in the setting of surgery, but what about our patients with thalassemia or sickle cell disease or myelodysplasia who might be transfused for months or years? How do we capture functional outcomes? And by that, I mean things like activity. Can the person walk upstairs without getting breathless? Can they look after themselves at home? Can they go out and do their shopping because they're less breathless after a transfusion or not? How do we know these things? And how are we aware of and take action to minimise the long-term complications, such as iron overload, but of course other potential complications of transfusion? So in fact, I think even though it seems quite simple, we know how to give a blood transfusion, there are many things that we don't know or that we are not doing. So in Australia, we're very fortunate to have some national PBM guidelines. These are all under review presently to try to update them with the most recent information. They're all freely available on the web for anyone who would like to make use of them. But the problem is that when those guidelines were written, and still today, they have relatively limited evidence bases. So we need better evidence to guide our clinical practice. And I mentioned earlier that for many clinical settings and for many patient groups, we actually have no information about how to best make decisions and transfuse those patients. So I like this summary from Cochrane, and I apologise I've not put in the citation here, that evidence-based medicine takes the best external evidence, we combine it with our individual clinical expertise and patient values and expectations, and try and come up with the best approach. And I think that what we understand by these evidence gaps really has a major implications for our design of clinical trials and how we interpret them. So I think it's no longer good enough to say, oh, the person's hemoglobin went up. I think that is maybe helpful as far as it goes. It's certainly something objective that we can measure. But I think we really do need these functional outcomes, these health-related quality of life data and patient-reported outcomes, and very importantly, health economics analyses when we're designing and interpreting clinical trial data. So just as an example, some of you will have been part of, and some of you or others of you will know about this first international consensus conference on PBM that was held in 2018, hosted by the European Blood Alliance and sponsored by many other groups, including ISBT. And the recommendations were published in JAMA the next year, trying to take advantage of all the people in the room to try and understand what is the evidence base and what do we need to do better. And so there were a number of themes of this conference, and one was focused on red cell transfusion thresholds and what should those thresholds be in different clinical scenarios. So here, for example, are clinical scenarios, the critically ill patients in intensive care, cardiac surgery, etc. For those ones, we could make quite a strong recommendation, but only based on moderate quality evidence, because at least there were randomized trials in those clinical settings. But for these other ones, you can see that the colour gets less and less red, and in fact, for some of these ones, there's really very little evidence on which to base our practice, including this large group here in haematology oncology. And why does this matter? Surely most blood is pretty safe these days. Well, yes, it is. But it can have long-term consequences for individuals and their families and the community as a whole. So some of you will know about the UK infected blood inquiry, which is going on presently. And you can see here that in spite of the fact that the UK has had multiple inquiries over decades, this inquiry is really because people felt that their concerns had not been addressed about how they were treated, but also to make sure that in the future we will do things better. So the question that the inquiry will examine is why women, men and children were given infected blood, the impact on their families, how the authorities responded, the nature of any support provided, questions of consent, and indeed whether there was a cover-up. And you can watch this. They have a YouTube channel, and they have a Twitter account, and you can see here the chair of the inquiry encouraging people to come forward and engage with the inquiry, but understanding that this was difficult for people to do because there's been a lot of stigma about transfusion-transmitted infections. And the inquiry allows people to give evidence while keeping their identity private if they wish that, and also to work directly with a trained social worker to provide their statements if people are not comfortable to give evidence in public. You can see here that they have interviewed the most senior people in the government, the Minister of State for Health and the Chief Secretary to the Treasury. These are all posted online. Anybody can attend, dial in. You can see here that here is a former senior government minister being questioned by the council for the inquiry. And they also interviewed many experts in the field, such as the risks of variant CJD and other infections. And many of you will know Professor Mike Murphy from Oxford, and he and many other clinicians have been asked to speak to the inquiry. And some of the questions that they were asked about was, what was the process at the time? This is in the 1980s and 90s. What were the processes in place in your hospital to ensure that patients only got appropriate transfusions, and how were they informed? Now, I think it's very hard to try and go back over these decades and find records and remember what happened and why. But I really commend the inquiry and all the participants for their willingness to be open, because it reminds us, here is a lady and her daughter whose husband and father died from a transfusion complication related to one of these infectious diseases, that people are still living today with the consequences of either the wrong blood to the wrong patient at the wrong time or for the wrong reason. And it is literally heartbreaking to watch these testimonials from patients and their families, but I think it's very important that we remind ourselves. Many of the people in the audience, like me, will be old enough to remember some of this, and many of the young people will never have lived through this. But I think it's something we need to do as a community, to be very open. So how can we involve patients more in some of these decisions and the processes? I've modified this a flow chart from a very nice review paper by Rachel Davis and Mike Murphy that was published more than 10 years ago now. But it is really an excellent summary of how patients can be involved and should be involved at every step of the transfusion process. They can be part of the decision to transfuse. They certainly need to be part of the discussion around the risks and benefits so that they can provide informed consent. They can be part of the safety processes so that when they're having a blood sample taken for pre-transfusion testing, they can participate properly in the patient identification and make sure that everything is being done right. At the bedside, when it's time for the transfusion, they can be active participants in their identity check to make sure that the product is the one that's meant for them. And of course, during the administration of the blood transfusion, they can alert the staff if they don't feel well. They can monitor their own observations, and they need to be aware that when they go home, if they have some signs or symptoms that suggest there's an adverse event, that they know what to do and get in touch with the clinical service straight away. So I just finish on the infected blood inquiry by saying I really admire the way in which this is being done. You can see here the 6 key principles governing the processes of the inquiry, focused on people, to be very thorough, to be respectful for everybody who's participating, to be open and transparent. The inquiry is independent of government and will make its findings independent of government, and that it will listen to the people who are saying what did happen in the past and how can we improve things for the future. So even if we are not involved in such an inquiry, I think there are things that we can all learn. So how do we actually know if our practice is appropriate? Well, there are a number of ways, and this is an example of our practice improvement program in Victoria, where I live, and I've been involved with this for literally 20 years. We're having our 20th anniversary celebration. And the program is called Blood Matters. And you can see here that there are a number of different activities, including focused on patient blood management. We have a serious transfusion incident hemovigilance reporting system. We conduct audits, and we provide information for patients and families around transfusion. We also train transfusion nurses, and there are many other aspects. And one of the things I like about this program is that our patient blood management is embedded in all of these other aspects. So it links with our hemovigilance program, it links with our audit program. And some of you will may have heard me speak just a few days ago on PBM and auditing at the ISBT Congress. But here's just a list of some of the recent audits that we've done at a statewide level to try and improve our practice by all of us auditing our practice and sharing our results and finding what we can learn. I talked in that presentation about the audit we did for preoperative anemia assessment and management in elective surgery. The UK also has a terrific national comparative audit program which has been going for a number of years now, and they also make all of their materials, as do we, available on the internet. Anybody can look at the reports. All the tools are also there, and I think one of the nice things about patient blood management is that everyone is willing to share their experience and their resources. Australia also has a blood safe e-learning program which everyone is welcome to use. Hundreds of thousands of people, mostly in Australia but all around the world, have undertaken some of these courses. They're all online. In our hospital, it's a requirement for new interns to do some of these basic courses before they start work with us, and these are very engaging and easy to use educational materials. So I just want to finish with another image from SHOT. So I know I was saying how SHOT's been publishing reports every year saying we still have a lot of work to do and that many of our major risks are people like us making mistakes. Well, that's still true, and we do have a lot of work to do. But you can see here when we look at the number of very serious complications such as ABO incompatible red cell transfusions, that over time those numbers are going down. Even though more cases in total of adverse events are reported to a SHOT and more hospitals are participating, overall we are making progress. So I think our transfusion is becoming safer, and I think it's becoming more appropriate as we all take up the principles of patient blood management. So I'll finish here and say thank you very much for the invitation to speak at this important event. ISBT is very happy to partner with you in it. I want to acknowledge all the people who helped me do my work, my hospital colleagues, my research unit colleagues, and my colleagues and friends all around the world in patient blood management, haemovigilance and research. Thank you very much for your attention.
Hello, ma'am. It was highly informative lecture regarding appropriate blood transfusion. It starts right from the donor selection, donor counseling, and you rightly described right blood, right patient, right time, right reason. So I think all of us have gained so much from your topic and from your talk, ma'am. It was highly informative. Thank you so much.
You are a natural speaker.
Yes.
And your lecture was thoroughly comprehensive, very enlightening. We are really grateful to you. You have applied your mind to every minutest detail, and it would be useful for everybody sitting in this hall. And we would try that your lecture is sent to every blood bank of this country. Thank you very much.